very effective in appropriately chosen candidates. So the main goal of an epilepsy surgery workup is to try to identify where the seizures are coming from and also determine whether it's safe to remove that region of the brain. And that is the reason why we usually do a whole host of battery of tests to determine the answer to that question. The workup can include a video EEG, a special MRI scan, a neuropsychology evaluation, as well as here at UCLA we always do a PET scan as well. And that's where we look at the data and determine whether more testing is required or not. In situations where the workup is quite straightforward and very quickly we can figure out what part of the brain the seizures are coming from, we can generally suggest a surgery in the form of a resection, meaning to remove that abnormal area of the brain in order to stop the seizures or cure the epilepsy. And in best case scenarios, our chances of seizure freedom are close to 80%, which although it's not 100%, it is much, much better than further medications because the children that we're offering these surgeries to, they've already failed at least 2 anti-seizure medications, if not more. So the likelihood of more medications working is pretty low. Now, in situations where the workup is inconclusive, we may suggest further testing, and in certain situations, we may suggest a special invasive EEG surgery. This is a diagnostic operation where we access the brain and we place small electrodes right on the surface or deep in the brain to try to pinpoint exactly where the seizures may be originating from. Depending on what that shows, your child may or may not be a candidate for a further resection operation. Resections can be as small as removing a tiny part of the brain, or it can be as large as, especially in very young children, as large as an entire hemisphere of the brain, a procedure called a hemispherectomy, where we completely remove or disconnect 1/2 of the brain to treat pretty serious seizures. Nowadays, we have multiple other options as well in children that don't have any clear focus for their seizures or if they have multiple foci. One option is implantation of a vagal nerve stimulator, which has been around now for quite some time. It's an outpatient procedure, meaning the child will go home the same day as well. Requires a small incision on the neck and a small incision in the chest, and we insert a battery generator that will disrupt the seizure activity and frequently lower the seizure burden and usually make the seizures less severe. There are quite a few other options as well. There's a new device that's FDA approved in adults, but we have been using them in children quite often. It's called a responsive neural stimulator. This is a device that we can use to, it uses smart technology to not only detect and do a 24/7 EEG on a specific area of the brain, but if it detects the start of a seizure, we can train this device to send the impulse and the stimulation to stop that seizure from spreading or sometimes stop it from ever beginning. This is also an implantable device. The device goes in the head and it sits actually inside the skull, and the battery life is actually quite good. It's up to over 8 years now. This is an approach in situations where we cannot remove a certain area of the brain because it has important function. So let's say that area is involved in language function or motor function and it would not be acceptable to remove it physically, we would suggest this RNS device as well. Lastly, I'll talk to you about a minimally invasive laser ablation. So this is a tool that we can use to access really deep areas of the brain, specifically in small regions, where we can target that area of the brain by putting a special fiber inside the brain, right where the abnormality is, and using heat energy to destroy those cells. And the nice thing about that approach is we can avoid a large scar on the head, so a craniotomy, which is a traditional way to do surgery. Not every child is a candidate for every surgery, but we make these decisions in a multidisciplinary fashion and considering all pieces of data for that individual child. What I wanted to briefly focus on today is surgery after surgery. So whenever we think about failed epilepsy surgery, we have to think about what was the reason why we failed. So in certain situations, we identified exactly, correctly where the seizure is coming from, but we did not remove enough brain tissue, meaning that we did not remove all of the abnormality. In those situations, we can go back and obviously determine in which direction the abnormality still exists in the brain relative to where that previous resection was, and obtain seizure freedom in certain children. There's also the situation where the epilepsy team was completely wrong in determining where the seizures were coming from, and that may be a reason why the surgery didn't work. So in those situations, we need careful testing and sometimes very specialized testing to help us exactly figure out where those seizures are coming from if it was missed the first time. Other situations where the seizures may be coming from different foci, different parts of the brain, and those obviously usually are not addressable with surgery, quite easily, but we can, I should say, at least with traditional resective surgery, but we can definitely target those areas either directly through this responsive neural stimulation system that I talked about, or sometimes if there's even more than two, with deep brain stimulation, which is a up-and-coming newer way to treat multifocal epilepsy, where we place electrodes deep into the brain, into certain nodes in the brain that are really involved in epilepsy, and we can, again, obtain really good seizure reduction rates, usually not seizure freedom, but seizure reductions in the vast majority of patients. Lastly, there is also the situation where the epilepsy surgery may have worked initially at stopping the seizures, but then another area of the brain decided or developed its own ability to generate seizures. And the workup is quite similar, or would restart the workup from the beginning to try to figure out where that second area is and try to target that. That would be more common in situations, in very specific situations, such as tuberous sclerosis complex, which is a rare genetic disorder that a lot of children suffer from epilepsy, or focal cortical dysplasia, which is a more common condition that we treat, but the MRI findings and dysplasia can be quite subtle and difficult to find. So needless to say, any child that has failed previous surgery, I would strongly recommend that they have an additional workup to make sure that there's any other options. We always have options. Generally, we are first looking to curative options through resections or ablations, but in situations where cure is not possible, there's still other palliative surgical options which are meant to really lower the burden of epilepsy, if not stop them completely. I'm going to stop there. I'd be happy to answer any questions over email. Sorry again that I couldn't be there in person this year. This is a fantastic event, and I look forward to being there next year. Thank you.